That was excellent. I'm bringing on Dr. Katie Lynn from Calgary, an emerge specialist, and you did a specialty in stroke. Had to do that too.
That's right, I'm just a big nerd. Yeah.
So I'm sure this will be brilliant. Dr. Lynn.
Well, thank you very much. And I'm just going to start by saying it's honestly it's an honor, and it's so humbling to be here with all of you today. I'm especially excited to speak with you about a topic that is near and dear to my work as both an emerge and stroke physician. Today, we're going to conquer the crashing brain and talk about neurocritical care priorities in the setting of intracranial hemorrhage. I'm going to start by introducing this individual, and this is for my fellow nerds in the audience. I know you're out there. Those of you who are kind of following HBO and shows out there, you'll recognize this individual as Daenerys Targaryen, also known as Khaleesi and Mother of Dragons. But behind the scenes, she's Emilia Clarke. She shared her story with the world with a New Yorker article in 2019. So let's rewind to 2011. Emilia was 25 years old. She just finished filming season 1 of HBO's Game of Thrones, and she'd been thrust into this newfound world of celebrity. But her life was about to change in a very different way. It was during a particularly strenuous gym workout session when suddenly she developed a severe headache, followed by nausea and vomiting, blurry vision, aphasia, and altered level of consciousness. She was rushed to a nearby hospital where she was diagnosed with an aneurysmal subarachnoid hemorrhage. It would be the first of 2 ruptured aneurysmal subarachnoid hemorrhages that would go on to threaten her life and require endovascular coiling, an OR for surgical decompression with a hemicraniectomy, and ultimately admission to the ICU. Thanks to the meticulous and timely care of her medical team, Emilia would not only go on to survive from her injuries, but she would actually have a profound neuro-intact recovery and continue her acting career and become an advocate for stroke awareness and neurorehabilitation. I share Emilia's story with you today for 2 reasons. 1, because we remind ourselves of the people behind the disease process. The decisions that we make have a weight to them, and what we do matters. And 2nd, intracranial hemorrhage has a very high mortality rate. We can't always turn the tide of disease, but sometimes we can. And it's in those cases where the early moments matter the most. So throughout this talk, I want you to envision that you're in your emergency departments with your teams when a patient like Emilia walks through the door. We're going to focus on early identification of impending and evolving neurodisasters and how to safely initiate neuroprotective resuscitation when you know you have a sick brain on your hands, but you don't know exactly what kind of sick brain you're dealing with yet. Broadly speaking, we have 2 sick brains that we encounter clinically, right? We have the stable sick brain and the crashing sick brain. The stable sick brain is one where cerebral autoregulation is still at play. The brain is compensating for whatever pathology is going on, for now. Problem is, we know that autoregulation works until suddenly it doesn't. And we don't know when that cliff is coming. So we need to identify it early. The crashing brain is one that has completely fallen off of that cliff already. Things are moving really fast now. The GCS is dropping, and you're rapidly running out of time to save this patient's life. When we think about non-traumatic acute neurodisasters, we tend to think of them in 2 flavors, broadly. There's the ischemic strokes. About 80% of cases that we see are going to be these. And then about 20% of the time, we're talking about hemorrhagic conditions, your subarachnoid hemorrhages, your intracranial hemorrhages. Our gut tells us that there are certain symptoms that predict whether the patient in front of us is more likely to be hemorrhagic, right? So the super low GCSs, the seizures at onset, severe hypertension, super bad vomiting. But the truth is, when we look at the data, unfortunately, we have to admit to ourselves that there are no reliable clinical features to consistently distinguish between these subtypes prior to imaging. So at the back of our minds, as we manage these cases, we're thinking to ourselves, how do I temporize this patient and get them to the CT scanner quickly and also safely? We're going to break it down into 3 phases of our approach. In homage to the good Dr. Justin Morgenstern and his First 10 EM team, we're going to start with the first 10 minutes. What are our initial management priorities when we first get to the bedside? And then the CT checklist. How are we going to safely ensure that that patient can get to the CT and back when we know that there's a dynamic brain process going on? The donut of truth is a phenomenal diagnostic tool, but it is a terrible venue for intubating and resuscitating. And I know I'm not the only one who has lived that. And then once we have our diagnosis, how are we going to tailor our therapy for the patient in front of us? In our first 10 minutes, we're going to focus on the bread and butter, the stuff that you all do so well already with your primary surveys, your ABCs, do what you would normally do. I'm going to touch on 3 particular elements. How do you tailor your rapid neuro exam when seconds count and the patient is crashing fast? How are you going to empirically target your blood pressure when you don't yet have your imaging to tell you what kind of sick brain you're dealing with? And what are some neuroprotective airway capture considerations that we might want to keep in mind? In your first 10 minutes with your rapid neuro exam, if you've got time, patient's stable, flesh out your neuro exam, great. But if your patient is crashing and you only have a few moments, these are really the only 2 things that we care about. Are there major focal deficits present? And are there signs of impending herniation? We don't have to get fancy with it. Thankfully, most of that information is available to you up front with your GCS survey. What's the patient's level of consciousness, and is it dynamically changing? Collateral history from your EMS crew, so helpful here. What are the eyes doing? Are the pupils equal and reactive? And from a motor standpoint, have I personally seen with my own eyes that the patient is spontaneously and purposefully moving all 4 limbs, or are there signs of lateralizing features or posturing? Blood pressure targets. Most of our patients are going to be hypertensive as the brain tries to compensate and auto-regulate and keep that cerebral perfusion pressure going. I and many other experts are going to recommend you target an empiric systolic blood pressure of less than 180 in these patients. Why 180? Because it's generally a safe target, regardless of what kind of sick brain you're dealing with. If this is an ischemic stroke patient, you get your diagnosis, you can proceed directly to reperfusion therapy, thrombolysis, or endovascular therapy. If it's hemorrhage, you've already started to limit hematoma expansion in those early stages. Why not lower, you might ask yourself? Well, as we talked about earlier, we cannot reliably clinically distinguish between hemorrhage or ischemia without our imaging. And the last thing we want to do is hypoperfuse a brain that's trying to drive blood pressure past an occlusion. And if, on the other hand, your patient is hypotensive and you know they have a sick brain, we need to act very quickly. We know that hypotension is independently predictive of mortality, even a single reading. So keep that mean arterial pressure above 80 and start your vasopressors early. How are we going to achieve those targets? We're going to start by layering in the low-hanging fruit. Antiemetics and analgesics first. We know that vomiting raises and spikes ICP and also compromises our airway. It slows us down from getting to that scanner safely. Analgesics. Many of these patients have headaches, severe pain that they may or may not be able to communicate to you, so think about whether that's something you want in your arsenal. And specific antihypertensive agents. So first line in an ideal world would be nicardipine. You can start that as an infusion. It's got a nice, smooth blood pressure response. Problem is, it's not approved for use in Canada, so I don't have access to it in my emergency department, not easily at least. So instead, I'm going to reach for the second line, labetalol. 10 to 20 milligrams, IV push every 5 minutes. If you find the patient is responding, but you need to redose it frequently, you can start an infusion instead, 1 milligram per minute. Titrate from there. If your patient is not responding to the labetalol, or if they are bradycardic at outset, heart rate less than 50 to 60, maybe you want to go with hydralazine instead, or use it as an adjunct, 10 milligrams every 15 to 30 minutes. What I do want to point out, though, is that we want to avoid nitro-containing blood pressure agents, nitroglycerin and nitroprusside. The reason for this is, as tempting as it may be to reach for those agents, we're familiar with them from other medical contexts, they actually dilate the meningeal blood vessels and raise ICP. So your monitor is going to be looking better, but your patient's brain is actually going to be doing worse. Avoid nitro-containing agents. In these patients, we have a lower threshold to intubate pre-CT. Things that are going to push us there. Respiratory distress or failure, low or dropping GCS, if they're actively vomiting or have a soiled airway, and severe agitation I'm going to throw on that list as well. the kind of agitation that makes you reach into your back pocket for that last little dose of ketamine that I know you've all been stashing during the shortage. Sometimes the safest approach for these severely agitated bad brains is actually airway capture. How are we going to do it? In the crashing brain, we don't actually want to overcomplicate things. We're going to go with what we know and what we're comfortable with. Rapid sequence intubation, RSI. For induction agent, whatever you're comfortable with. Is that ketamine, etomidate, propofol? Use the tools that you know well and that you're comfortable with. What about your paralytic agent? My personal go-to, rocuronium, non-depolarizing. That's what our neuro anesthesia colleagues tend to use. Don't spike the ICP. But again, the literature on succinylcholine and ICP spikes, it's very short-lived, and we don't know if it has any clinical impact. So use what you know and what you're comfortable with when the patient in front of you is very sick and you need to act quickly. If you have a little bit more time to optimize, you can throw in some things that can help us with our neuroprotective intubation, things like fentanyl pretreatment, right? 3 to 5 mics per kilo, given 3 minutes before your induction dose. You can also get lidospray, spray down the cords, reduce that ICP spike from your laryngeal manipulation. At its core, neuroprotective intubation boils down to 2 things: avoid hypoxia and avoid hypotension. And I know that you all do that very well already. Your first 10 minutes are up. You've examined your patient, you've started some blood pressure management, and you've talked about how to capture that airway. Next, we turn to how to get that patient safely to the CT scanner and back. We're going to prepare and anticipate. Have we talked about an airway plan with our team, especially if we haven't yet captured the airway? Have we layered in some antiemetics, especially in that non-intubated patient? Have we thought about which antihypertensives we want to use, and are we prepared to send the team with some in case the patient's blood pressure spikes again? And have we thought about our agitation and sedation plan? Have we gotten good IV access before that CT scan? It's a lot easier to secure that in a well-lit emergency department than the dark bowels of the diagnostic radiology department. And what kind of imaging are we going to get? CT or CTA? If it is available to you, CT angiography should be the imaging of choice for any patient who presents with focal neurologic deficits or sudden unexplained low GCS or coma. CT angiography gives us so much important information about the vasculature. In an ischemic stroke, it is much more sensitive for identifying early ischemic changes and showing us where that occlusion is so we can plan for definitive management. It can also identify basilar artery occlusions in that patient who looks like they're comatose suddenly, but is actually locked in. In a hemorrhagic stroke, it still gives us important underlying structural information. Is there an AVM? Is there an aneurysm? Or is there what you see here, which is called a spot sign? If your radiologist reports a spot sign, this means that the patient still has an ongoing arterial bleed underlying that intracranial hemorrhage. If they look okay right now, they're at incredibly high risk of deteriorating rapidly. This information needs to be passed on to our consultants. And so now you have your imaging, you've diagnosed your intracranial hemorrhage. We're going to focus on some definitive management and image-guided therapy. We're going to consult and get that definitive management going, do serial assessments to monitor for dynamic changes, and we're going to support and maintain that patient's neurophysiology to avoid secondary injury. Neurocritical care is a team sport, and I mean, it goes without saying that emergency medicine is the coolest and obviously most central part of that team. But we do rely on our talented colleagues to help us manage these very sick patients. So assemble your team early. There's reasons for all of them being labeled the way they are, but I just didn't have time to go through it. And of course, until our colleagues arrive, that patient is ours. We are the eyes and the ears at the bedside, and we're watching for that dynamic decompensation so that we can speed things along if we have to, right? It's a changing process, and that trend over time is so important. Raised ICP is what we're looking for. So worsening of your headache, worsening of your focal deficits, worsening of your nausea and vomiting, dropping of your GCS, pupillary changes. These are all things that we are looking for. And of course, we're looking for that dreaded Cushing response. This is what the brain does when it is squeezed. Blood pressure goes up, heart rate goes down, and breathing becomes irregular. I do want to highlight that not all herniation comes with a blown pupil. There are multiple different kinds of herniation depending on where that lesion is occurring. For example, subfalcine herniation happens high up. It actually doesn't have any overt pupillary effects, but you will see raised ICP symptoms. You will see clinical changes. Central herniation actually gives you small pinpoint pupils. With their low GCS, these patients can actually come in looking like opioid toxidromes, but they're not going to respond to Narcan. Uncal herniation is what we're used to seeing with the blown pupil. And tonsillar herniation gives us mid-position fixed, non-responsive pupils. So just remember that not all herniation comes with a blown pupil. We need to be looking for pupils plus these clinical signs of raised ICP and Cushing's. And remember that the Cushing reflex triad is a triad. Blood pressure we know about going up, heart rate we know about going down, but respirations also become irregular. There are two particular patterns that we see with herniating patients. We see Cheyne-Stokes, which is this crescendo-decrescendo pattern of breathing with apneic pauses, and we see Biot breathing, which is this deep, regular respiration, kind of like Kussmaul breathing almost, but with these apneic pauses. Irregular resps with apneic pauses, super, super bad marker. I'm going to introduce you to a term called euboxemia, which one of our neuro-intensivists taught me. This is where we take all of our vital sign boxes and we make them and massage them so that they're nice within a normal range, that Goldilocks zone that the brain is so happy with. So in an intracranial hemorrhage, systolic blood pressure, we're going to target 140 to 160. Avoid hypotension and avoid wild swings in blood pressure. PaCO2, we're going to target 35 to 40, that Goldilocks zone. If the patient is herniating, we're going to shift that a little bit lower, 30 to 35. SATs greater than 94%, great, happy. Temperature below 38, and better yet, get on it early. When they get to 37.5, start thinking about getting an antipyretic on board. And keep your glucose between 4 to 10. Dr. Walter Himmel is going to give us a masterclass in anticoagulation reversal, so I will not go into it in depth here, but I will touch on a few things. If you think your patient has taken an oral anticoagulant within the last 24 hours, whether that's a vitamin K antagonist or a DOAC, do not hesitate to empirically reverse them. Do not wait for your coagulation studies. Do not worry if they have a mechanical heart valve. Do not hesitate to empirically reverse them. And if you are going to reverse them, go big or go home. 2,000 units of PCC, maximum empiric doses. When we talk about ICP, we can think about it in multiple tiers as well. Tier 1 is the low-hanging fruit, things that we can easily do at the bedside initially. Raise the head of the bed, loosen any constriction around the neck, and layer in your antiemetics and your analgesics like I talked about. Tier 2 is for the patient who's continuing to deteriorate on you. We're going to hyperventilate them down to a PaCO2 of 30 to 35. You can deepen your sedation and paralysis in that patient, and you can reach for hyperosmolar therapies, of which there are multiple kinds. Hypertonic saline, reasonable choice, 3%, 3 cc's per kilo, or if you want to keep it simple, 250 cc bolus, up to a maximum sodium of 155. Or you can go with mannitol, 1 gram per kilogram. I like to keep it simple, 50 grams for a small adult, 100 grams for a large adult. And if you have neither of those readily available, you can actually reach into your crash cart and pull out some sodium bicarb. This is equivalent to 6% saline solution, so twice as potent as your standard 3% hypertonic saline. In a pinch, you can use sodium bicarb. And finally, the really invasive stuff. Phenobarb coma, external ventricular drain put in by neurosurgery, or neurosurgical operative decompression with a hemicraniectomy, like what Amelia had. So ultimately, we remember that serial assessments are key to the crashing brain because this is a dynamic process and this is going to allow us to pick up on changes early. Empiric resuscitation we can think about in 3 stages. First 10 minutes, your safe to CT checklist, and image-guided targeted therapy for the patient in front of you. Thank you very much.
Thank you, Katie. Seems so simple.